We're going to finish off the morning with a talk on vascular diseases of the thorax, and then we're going to do some cardiac and vascular cases. So let's go to the cases. And I think this is a history of trauma, but even if it wasn't a history of trauma, it'd be nice to have a generalized differential for this finding. And again, I said, before, a lot of chest radiologists knowing the pattern in which to put it into. And if you get the right pattern, the differential is usually pretty straightforward. If you get the wrong pattern, you're totally in trouble. So what's the pattern, and then in the history of trauma, what's the general differential, and then what's in the history of, with that history of trauma, what are you going to think about as a cause for this abnormality? What kind of image is this? This is a sagittal MR image, sort of oblique sagittal, and you maybe a clue. That's a blood vessel, and what is the blood? What color is it? Black. So that may be a clue as to what kind of MR sequence it is. And then what's the abnormality? This is someone with hypertension. Very simple, black blood. I like that. All right. What kind of image is this? This is a coronary. This was a patient with chest pain and they got a coronary CT. So how have we reformatted this image? That'd be one question. What kind of reformat is this called? And then is this patient's chest pain due to coronary artery disease or not? And what should do next? Here's another patient with chest pain. Actually, I think this patient's actual history was sudden death. I'm always a little bit, I don't quite understand how they get on the CT scanner with sudden death, but usually it's like a family history of sudden death or syncope or even worse, pre-syncope. This patient actually did have an abnormality. Okay, what's the abnormality? Is it clinically significant? Then what's the potential treatment? And lastly, what kind of sequence is this? This is the heart, an image of the heart, sort of coned down, just the heart. And this is, sort of the nukes image, right? The donut view here of the left ventricle. And what you should know is what type of sequence is this? Particularly, why is the myocardium so black here? And then why is it not homogeneous all the way around? What's that stuff? So what caused this, and then what do we do for this patient? Probably one of the most important indications for cardiac MRI that you can imagine is right here. Okay, all right, good. So, history of trauma, what are we going to worry about? What's the pattern? Widened mediastinum, right? That's the pattern. Some people misinterpret this as right upper lobe collapse because there's this kind of opacity sandwiched here against the mediastinum, but it really is widened mediastinum. And what's the number one cause of a widened mediastinum in the setting of trauma? That's a baited question. It's actually not traumatic aortic injury, even though that's what you have to exclude. All right, history is trauma. So let's talk about the chest x-ray signs of traumatic aortic injury. I break them into several categories, mainly two. One is the mediastinum's too big, and the best measure of that is your experience having seen a lot of chest x-rays. If you like numbers, here's a few numbers, but I don't use these numbers at all because I find better to sort of weigh, how good a quality is it, what's the inspiration, et cetera. And then the aorta looks abnormal. It's either too big or it's very indistinct. Those are the main two. There's some other ones we talk about. The hematoma associated with traumatic aortic injury can cause mass effect on NG tubes, ET tubes, things like that. And you can get an apical cap, which is essentially blood layering in the mediastinum into the lower neck above the lung. And then you can get pleural effusions or hemothoraces associated with traumatic aortic injury, but mainly it's these two. Mediastinum's too big, aorta's abnormal in some way, okay? And so what's the significance when we see a chest x-ray like the one I showed you in the setting of trauma? We presume that a lot of what we're seeing is blood. So the question is, what's the significance of blood in the mediastinum in the setting of trauma? And the answer is that the majority of cases of mediastinal hemorrhage in the setting of trauma are actually venous bleeding, these little bridging mediastinal veins that bleed, and they can bleed a lot, and you don't really do anything about them other than conservative treatment. Of course, you have to, other causes of hemorrhage in the mediastinum are fractures, and then the diagnosis you really need to exclude is traumatic aortic injury because that's the life-threatening one. The majority of cases of traumatic aortic injury at least begin or are only located in the region of isthmus because that's an area where you have a fixed portion of the aorta next to a mobile portion of the aorta, and when you develop trauma and you get shear forces, those two separate and you get a tear right at that location. Another site of fixation would be at the diaphragm, at the when the aorta passes into the abdomen. That's sort of fixed next to mobile area. Ascending aorta, this is from the pathology literature. 5 to 10% of traumatic aortic injury is in the ascending aorta. Of course, they don't tend to make it to the CT scanner, so we almost never see isolated ascending aortic injury. And then injury at the takeoff of the great vessels is actually fairly common. And again, it's a site of fixation versus a site of mobility, so they tear right at the origin. Okay, here's the CT scan on the patient I showed you with the wide mediastinum on chest x-ray. We see a few findings. We see a lot of blood in the mediastinum. That mediastinal fat has now been replaced by all this amorphous high-density material. And not only that, we see a little focal saccular outpouching right in the region of the ductus or the ligamentum. And that's a great site for traumatic aortic injury. Looks like a pseudoaneurysm, focal saccular outpouching with a narrow neck. On the sagittal reformat, you can see it nicely. Here's ascending aorta, a bit of the arch. We're just out of plane here. And then there's that nice focal saccular outpouching with a narrow neck. What happens to this patient? Go right to surgery. Do not pass go. Do not collect 200. Okay? No need for any other additional workup. You can break up the CT signs of traumatic aortic injury into two groups. One is direct signs of aortic injury, and if you see that, they go to the OR without any additional workup. And that's gross extravasation of contrast, which is rare, pseudoaneurysms, which is probably the most common. And what do pseudoaneurysms look like? Focal saccular outpouching with a narrow neck. Intimal flap, resembling a dissection, but you have a history of trauma. And then any wall irregularity that you can't just blow off as being atherosclerosis could be traumatic aortic injury. And there are also indirect signs, and mainly the indirect sign is mediastinal hematoma. Okay, so direct and indirect signs. The question is, what do you do when your patient has mediastinal hematoma but doesn't have one of those direct signs for traumatic aortic injury, doesn't have what looks like a dissection, a pseudoaneurysm, gross extravasation, et cetera? The answer is, if the hemorrhage doesn't touch the aorta, like in this case of isolated prevascular hemorrhage, this actually patient has a sternal fracture, but even if they didn't have a sternal fracture, if you have isolated hemorrhage which doesn't touch the aorta, you don't need to do any further. CT scan confidently excludes traumatic aortic injury, and it's presumed either venous bleeding or, in this case, fracture. When the hemorrhage touches the aorta, this used to be, in the old days, they would go to angio. So you have no direct signs of traumatic aortic injury, and the hemorrhage is directly adjacent to the aorta. But in reality, in these days, with our really good scanners, the chances of angio picking up some subtle injury that we're not seeing on our nice 64 or 256 multi-detector CT is close to zero. So in the majority of these cases where you have a nice exam on a fast CT scanner, they'll maybe get a follow-up CT in a day or so just to make sure that there's no occult injury which you haven't seen originally. Here's examples of an abnormal aorta on chest x-ray, which is a common abnormality. The ascending aorta overlies usually the right pulmonary artery when it's too big or it's tortuous, except it has a very different morphology from the pulmonary artery, so you can almost always tell that it's the aorta that's dilated. The valve's going to be right about here, and then the ascending aorta, when it's abnormal, projects over the right pulmonary artery. Arch looks like the arch. Descending aorta is going to be in the retrocardiac region. You may want to stop before someone says, do you want to biopsy this? So it's in the differential of a middle mediastinal mass. Posterior mediastinal. Normal sizes of the aorta, it's less than 4 is considered normal. Between 4 and 5 is dilated. Above 5 is considered an aneurysm. Surgery, we always say 6, but in reality, 6 is the level where the incidence of rupture starts to increase significantly. So most surgeons like to do it a little bit earlier, usually 5.5 or so is when they'll do surgery. And in patients with connective tissue disease, like Marfan's and things like that, it's going to be a lot earlier than that. But if you like numbers, you can remember 4, 5, 6, but remember 6 is usually 5.5. Okay, so let's talk about acute aortic syndromes and aortic abnormalities. I think of these in pairs. One is the aneurysms and true and false aneurysms. Second pair is intramural hematoma and dissection. And the third is ulcerated plaque and penetrating ulcer. And I'll tell you why I think of these together. Aneurysms are just dilatation of the aorta. And it's important to distinguish a true versus a false aneurysm because they tend to be treated differently, and one is generally a higher instance of rupture compared to the other. Here's a nice black blood MRI, sagittal, showing a fusiform aneurysm. True aneurysms tend to be fusiform, involving the ascending thoracic aorta. A special type of true aneurysm is what we call annual aortic ectasia. That's where the aneurysm extends down to close to the aortic valve. It tends to be a different etiology, particularly it's classic of Marfan syndrome, and the surgical approach may be different because you have to do entire root and valve repair. Because often those patients, because the aorta is so dilated, it dilates the aortic annulus, and you get a lot of regurgitation associated with that. Some causes, just normal aneurysms, we think of atherosclerosis, hypertension, maybe post-stenotic dilatation due to aortic stenosis. When you specifically see annual aortic ectasia, you could think of Marfan's, Ehlers-Danlos, and maybe syphilis. Of course, we don't see a lot of that anymore. Okay, true aneurysms are fusiform. False aneurysms, such as this one, are saccular. And many people think that almost all saccular aneurysms of the aorta are false aneurysms, whether they have or do not have a narrow neck. But the classic is of a saccular aneurysm is a focal saccular outpouching with a narrow neck, a pseudoaneurysm. And the most common causes, which are obviously very different than the true aneurysms, are trauma, penetrating ulcer, and mycotic pseudoaneurysms. They're really pseudoaneurysms, not aneurysms. Okay, so that's aneurysms and pseudoaneurysms. What about intramural hematoma and dissection? Again, I think of these together because they have a very similar etiology in the majority of cases. Here's a nice example of intramural hematoma. We see this thickening of the wall of the aorta. Even on the non-con, it looks high density, but the contrast can be helpful. The non-contrast can be helpful to appreciate the high density nature of the intramural hematoma. Perhaps on this study, you would think it's atherosclerosis, although it looks a little bit too smooth and too high density, or maybe inflammation due to vasculitis, but the non-contrast can be very helpful to appreciate the fact that it is hematoma. The reason I think of this in the spectrum of dissection is that in most cases of intramural hematoma and dissection are due to hypertension, and the primary abnormality is bleeding of the vasa vasorum, and that will cause hemorrhage in the wall, and that wall weakens, and eventually, because of the shear forces of the hypertension, you eventually may get the actual intimal defect. So presumably, many patients who started who ended up as aortic dissection started at some point as intramural hematoma. Most common cause is hypertension. There are some other ones. Connective tissue diseases, penetrating ulcer in particular is not an uncommon cause of both intramural hematoma and dissection. And the treatment is the same as dissection, although particularly for ascending aortic intramural hematoma, surgeons have become much more conservative over the years and tend to treat those more conservatively, hoping they go away on their own with just hypertension treatment. Dissection, again, in the same spectrum in majority of cases, particularly the cases that are associated with hypertension. We have nice example of an intimal flap in the aorta. You want to identify the true versus the false lumen. The false lumen has several characteristics. One, in systole, where the pressure is higher in the true lumen, the flap is going to be convex towards the false. In diastole, that lumen may collapse. Actually, that's a poor prognostic sign as well, because you would imagine the lumen's collapsing in diastole in the true lumen, or the flap is collapsing, you may reduce perfusion to particular organs. The false lumen tends to be bigger, and you may see differential enhancement. Here's a nice example. This is early, and the blood is flowing more quickly here. So the contrast gets here easier in the true lumen and takes some time to diffuse into the false lumen. What's quoted as the most specific sign for the false lumen is these little bands of residual media left over here called aortic cobwebs. I don't find that a particularly helpful sign because I think perhaps the sensitivity is like 3% or something lower than that. The Stanford classification, which I hope you all know, we're from the West Coast, so we use the Stanford classification, even though there may be some sort of rivalry between UCSF and Stanford, but very simple. Type A involves the ascending aorta, type B doesn't. Type A is surgically treated in the vast majority of cases. Type B is medically managed unless the patient has intractable pain or end organ ischemia, in which case then you could consider a surgery in that case. Now, there are atherosclerosis, very common. There are certain inflammatory subtypes of atherosclerosis which we think about, which are sort of special situations. One is ulcerated plaque, where you have atherosclerosis and you get this little crater. You can see here this little crater within the area of plaque. That area of ulceration does not extend into the media. That's to distinguish it from a penetrating ulcer, which does. And this is associated with, if it's very extensive, may be associated with stroke and other embolic events, but by itself really isn't a significant abnormality. It's nice to know, but it's not clinically important by itself. It's not going to cause a patient to cause any major issues unless they have extensive disease. Penetrating ulcer is when that area of ulceration extends into the media. When it goes into the media, problems happen because now you essentially have a small little pseudoaneurysm because not all 3 layers of the wall are there. And you have blood in the lumen actually extending into the media. And so you can develop a lot of abnormal effects from that problem. Classically, it's arch and descending thoracic aorta. And the complications of a penetrating ulcer are intramural hematoma, dissection, rupture, and pseudoaneurysm. And probably the most common of those that we see, like we see in this case, is a pseudoaneurysm, where you have a focal little saccular outpouching from the aorta because not all 3 layers of the wall are there, and it weakens. So those are the acute aortic syndromes. Here's a classic chest X-ray, moving on to another topic, which shows opacity on either side of the trachea. And so it sort of looks the same, right? That looks like aorta, and then this also looks quite round. It's much too high to be azygous. So because of its appearance, we're considering some sort of aortic abnormality. It sort of looks like 2 aortas on either side. And there's an esophagram, which is classic. We have this posterior, smooth, extrinsic esophageal compression on the barium esophagram. So things that I would think about would be aberrant subclavian arteries, either a left arch with an aberrant right subclavian, or a right arch with an aberrant left subclavian, or perhaps a double arch, because I know in the double arch, the right arch tends to cross over at various levels and may produce this posterior impression on the esophagus. Here's this patient, nice example of actually this was not this patient, it's another patient, but a nice example of a left arch with an aberrant right subclavian artery passing between the spine and the esophagus. And virtually all of the aberrant subclavians will pass posterior to the esophagus. Okay, aberrant right subclavian artery. And in this case, the subclavian artery is the last vessel off the arch, goes posterior to the esophagus. When it's extremely dilated, we call that a diverticulum of Commerell. And then the classic PIMP is what is the symptomatology the patients with diverticulum of Commerell's may have. And the symptomatology is called dysphagia lissoria, where they have dysphagia related to this aberrant vessel. This is much more common in a right arch with an aberrant left subclavian, as opposed to a left arch with an aberrant right subclavian. That's symptom. Here's an MRI showing a nice example of 2 fairly symmetric, I guess the right arch is a little bit bigger, but 2 arches. It's a double aortic arch with a slightly larger right-sided aortic arch. And that right-sided aortic arch eventually crosses over posterior to the esophagus and will descend most commonly on the left side after some variable period of time. So again, the right arch tends to be larger. Occasionally you have one arch which is very, very small, or even is a little fibrous band. But the right arch is typically bigger. And eventually that right arch will cross to the left and descend on the left. And so on the esophagram, you may see compression which is high up, or in the mid-chest, or even lower down, depending upon where it crosses over. So this is a black blood image. Again, as we keep it simple in MRI and cardiac MRI, the blood is black, so we're going to call it black blood. This is a double inversion recovery sequence. We intentionally make the blood dark. And I'm not going to get into the physics of that because it's beyond the spectrum of this. But there is a nice example of a focal constriction of the very proximal portion of the descending aorta, right? Actually, posterior arch, descending aorta, right where we expect the ductus to come in. This is a nice example of coarctation. There are 2 types. The focal type, which tends to present in an elderly patient with hypertension, unequal blood pressure differences in the arms. And there's a more severe type, which is essentially a type of hypoplasia of the aorta, which tends to present in a younger patient because just the severity of obstruction is much more severe. But this is much, much, much less common than the focal type. The chest X-ray is going to show a big aorta, which is totally nonspecific, but it may show the figure 3 sign, which I'll show you an example of, and it may show rib notching, which is kind of a classic radiology PIMP with a classic differential diagnosis. CT and MRI are obviously going to be more diagnostic and are going to show the area of narrowing much better and show whether they're collaterals or not. And in the juxtaductal type, you see that, which I just showed you, is very focal constriction near the ductus. You'll see collaterals, and these collaterals are basically functioning to bypass that area of obstruction, and you can quantify whether it's a significant obstruction using flow quantification techniques. Okay, here's a nice example of the figure 3 sign. We see extra lobulations of the aorta, and essentially what this represents is the area of dilatation proximally and distally from the coarct. And actually, this is a patient who has just a tortuous aorta, giving the figure 3 sign, although this sign would be the same if the patient actually had a coarct. This is a pseudocoarct, where the aorta is tortuous but is not actually focally narrowed, or it's not a clinically significant narrowing at all. Here's a nice example of rib notching. You can see it there. And I think of rib notching as several categories. One, obstruction of the arteries, obstruction of increased vascular flow in general, giving big intercostal vessels. Venous obstruction, in which case the rib notching is due to venous collaterals. And then tumors of the intercostal nerve in particular, such as neurofibromas. And then primary osseous disease, such as hyperparathyroidism, which can produce areas of erosion. So I kind of think of categories of diseases more so than the individual. Okay, here's the MRI in the patient I showed you initially. This is a post-contrast MRA showing beautiful example of internal mammary and intercostal collaterals in a patient with a very classic juxtaductal coarctation. And what would be the next step in evaluating this patient with them on your MRI table? Well, one, we want to quantify the flow. And what we would do is we would quantify the amount of flow flowing through the descending aorta just distal to the coarct compared to the level of the diaphragm. In a normal patient, the diaphragmatic flow should be lower than the flow up higher because essentially your flow is coming off the intercostals. It's being taken away from the aorta through the intercostals. But in a patient with coarctation and has a hemodynamically significant narrowing, the flow is actually going to be bypassing that area via the intercostals, and the flow will be greater or even equal, but usually greater at the diaphragm because the flow is coming in through the intercostals. And that can give you a sense of how hemodynamically significant the area of obstruction is. So a different topic. This is an image from a coronary artery CT in a patient with chest pain. What sort of image is this? This is a multiplanar reformat where we have drawn a line through a vessel of interest, in this case the LAD, and the computer reconstructs a plane that always stays in the middle of that line so you see the whole vessel laid out for you, and then you can rotate around that axis. And what do we see? We see a very focal area. This should obviously taper slowly over time, and we see a very focal area of stenosis in the proximal LAD. So we get coronary CTAs for one, atherosclerosis, coronary artery disease, in patients with either acute or more stable chest pain looking for coronary disease. We can get it in grafts, we can evaluate stents, and CT is probably the best at evaluating anomalous coronary arteries. It's the preferred modality for looking at anomalous coronary arteries, which we'll talk about. Here are all examples of significant stenoses. The image over here is going to be the multiplanar reformat of the vessel of interest. A is going to be normal vessel. B is going to be the vessel, a cross-section of the vessel at the area of stenosis. And you can sort of develop your eye for what is considered a significant stenosis. Significant stenoses are generally greater than 50%. These are all examples of lesions which are greater than 50%. We quantify stenoses similar to a cardiologist would quantify stenoses on a cath. We try to make this study a cath equivalent. So we calculate the maximum, find the maximum area of stenosis, and we compare it to normal vessel, and we use the minimum luminal diameter at the maximum area of stenosis, and we compare that to the same diameter of the normal vessel. And we determine whether that's less than or greater than 50%. If it's less than 50%, significant coronary artery disease is excluded. Whatever the patient's symptoms are not due to coronary artery disease, you're done. No further evaluation is necessary. If the stenosis is greater than 50%, they will go to cardiac catheterization to confirm one and potentially to treat it. Because here's all examples of normal or less than 50% stenosis. Again, multiplanar reformat, cross-section of the vessel, normal vessel, and at the area of stenosis. No stenosis here, but here's a stenosis there and there. All less than 50%. Whatever these patients' symptoms are, it's not due to coronary disease, assuming all the vessels look like this. You're done with the perspective of evaluating coronary disease. I don't like to show data in this course, but this is the one example I will show. The advantage of CT is its ability to exclude significant coronary artery disease. So when you have a negative CT or the CT shows no stenosis greater than 50%, you're done. No further evaluation required. The positive predictive value, i.e. its ability to rule in disease, is not as good. There's a couple reasons for that. One is calcium. Here's an example of a LAD with a focal area of calcified plaque. That's a cross-sectional image of the vessel. Calcium blooms. It looks much bigger than it actually is. So we tend to significantly overestimate stenoses where the plaque is predominantly calcified. There's normal. You can see this. What would you guess? There's normal vessel before the stenosis and after, and I usually get anywhere from 25 to 80% on this one. This was a 50% stenosis. Doesn't look like that, but that's what it was, a lot less than we would have predicted. That's why the positive predictive value of CT is not as good. Moving on to this case. CT is the best modality for looking at this. Here's the aorta. Here's the right ventricular outflow tract. Normal right coronary artery originates usually directly anteriorly. Normal left main coronary artery originates posterolaterally over there on the left-hand side. So in this example, the right coronary artery is coming off with the left together from the left sinus of Valsalva. So when you're talking about anomalous coronary arteries, so this is the right coronary artery originating from the opposite sinus of Valsalva with the left. There's several courses that coronary artery can take to get back to where it should be. One is it can go right in front of the right ventricular outflow tract. Number two is it can go behind the aorta, and both of those are not clinically significant. They're not going to cause symptoms per se by themselves. Nice to know it before, 30 years down the road, the patient has coronary artery disease and needs to cath, and they won't be surprised. But the one that is most concerning is what we call the intramural or interarterial or malignant course, where it runs in between the aorta and the right ventricular outflow tract. That is the one that can cause arrhythmias and sudden death and syncope and whatnot, okay? This is a nice example of that. There's the left main. There's the right coming off with the left. Here's the multiplanar reformat just showing how it's narrowed, where it runs in between the aorta and the right ventricular outflow tract there. Here's an example of one which is not clinically significant. There's the normal right coming off from the right sinus of Valsalva. This is the left main, which actually runs behind the aorta. It's not running in here. This is the one we would be worried about if it was in here. It's running behind the aorta. That's nice to know, but it's not going to cause syncope, sudden death, etc. Okay, last topic is this. This is a delayed enhanced MRI. So what we do, and how do I know that? The myocardium, the normal myocardium here looks very, very black. And we do that intentionally. We make normal myocardium black on purpose. Okay, so this is the donut view, like the nuclear medicine view, at left ventricle, right ventricle. So we're mainly looking at the left ventricle. This is what we call a viability study or a delayed enhancement study. We give them gadolinium. Actually, we don't give them that much anymore, but we give them gadolinium. We wait, and we do an inversion recovery time to intentionally make the myocardium dark. Just like you can do inversion recovery sequence to make fat dark, you can do inversion recovery sequence to make myocardium dark. So normal myocardium is dark. Myocardium that enhances is abnormal. That's all abnormal myocardium, okay? There's a couple things that show enhancement. One is inflammation, like myocarditis. The other is scar. And in scar, we're thinking about myocardial infarctions. There are several things which don't show enhancement. I mean, obviously, normal myocardium won't show enhancement, but also hibernating and stunned myocardium, where you don't have cell death, will not show delayed enhancement. Particularly hibernating is important because you may have significant wall motion abnormalities, but there's no infarct. So the echo can't tell, but we can tell. Okay? When you see enhancement, you want to distinguish, is this an infarct or is this some inflammatory or infiltrative disorder? If it's an infarct, it's going to be subendocardial, and eventually it will become transmural depending upon how severe it is. It will also be in a very specific vascular distribution, LAD distribution, circumflex, right coronary, whatever. Things like myocarditis tend to be intramyocardial or subepicardial. There are areas that do not, which spare the subendocardium, and often is real patchy. You'll see a patch here, a patch there. It won't be in a nice vascular distribution. I'll show you examples of that later. And the role is mainly to say, in infarcts, is to say, if you have an infarct in the LAD distribution, if we opened up that LAD, would the patient regain any function by opening it up? Or is it just all dead tissue that's never coming back? And the answer is, if the enhancement takes up 50% or greater of the entire thickness, we assume that the patient's not going to regain significant function. Whereas if less than 50% of that thickness of the muscle is involved by enhancement, scar tissue, then it's worth opening up that distribution. Here's an example of an RCA infarct. The entire inferior wall is transmurally enhancing. That's all scar tissue. If you open up that occluded RCA, this patient's not going to have any benefit from that. They're not going to regain any significant function. Here's an example of another RCA infarct with a bit of normal myocardium. There's a bit of normal black myocardium, but it's not 50% of the entire thickness. So this patient, even though there's a bit of viable tissue, will not regain function significantly if you opened up that distribution. Here's someone, another short axis near the apex with actually an LAD distribution infarct. We can see this very subtle subendocardial enhancement. And if we measure the normal myocardium, the residual viable myocardium, it takes up actually a significant portion, greater than 50%. You should open up this LAD because they have the potential to regain a lot of function. And the last one is, this is a patient who has a wall motion abnormality involving the inferior wall and the lateral wall. Without any delayed enhancement, it looks thin, but we don't see that nice enhancing muscle. So when you see no delayed enhancement in someone who has a wall motion abnormality, the majority of those patients have hibernating myocardium, okay? Wall motion abnormality without delayed enhancement in a vascular distribution.